And now let me give you Peter, who will handle the Q&A. So we'd like to take questions from those of you in the audience for any panel member, and then obviously also I'd like to stimulate some dialogue, people free to make questions back and forth amongst each other. Woman in the center there.
Thank you. I notice there's one group that seems to me to be conspicuously absent here, and those are perhaps maybe one of the most important categories in healthcare, and that is the physicians who are at the front line. One of the reasons I suspect they're not being represented here today is they're just too busy to leave their patients. But no one really has addressed the issues that are plaguing physicians, and as an executive director of a medical society, I can tell you that we are losing physicians that are exiting from New York State fast and furious for many reasons, including tremendous increases in malpractice premiums, as well as unprecedented decreases in reimbursements. And I find many of them are just not able to keep their practices viable, and I get calls constantly from physicians who are leaving or literally going out of business, and I would love to hear someone address that issue.
Anybody want to take it here on the panel? Or we got...
I'm sorry, do you want...
Okay.
Hi, am I on? Again, I'm Troy Oshner with the New York State Insurance Department, and I noticed also that there wasn't a physician on here, but I agree that physicians are crucial to the whole piece of this working, in particular getting a lot more people covered and the demands on primary care. As you may or may not know, but I personally and Governor Patterson has worked very closely with the Medical Society. We have worked very closely with the Medical Society in developing a managed care reform agenda. In the 3 years I've been here, we've passed 2 large bills, as you may know, dealing with certainly a lot more to do, but incorporating much of the Medical Society's agenda and getting much of it passed. So it's not, we certainly are cognizant of it. We have recognized it. There's more to be done, and there's more that we will do. On the medical malpractice front, as you may know, there was 2 years ago a task force that was convened, a major effort to try and grapple with that issue. Unfortunately, we haven't been able to kind of do we did kind of put together a package of reforms that dealt with risk management, improved on the provider side, with insurance reforms to try and spread risk a little bit better, and also with tort reform, and for a variety of reasons that hasn't been as fruitful as we'd like, but we're not done. And I know the new superintendent, my boss, Jim Wren, has some proposals, including a risk service organization that would try to make clear what the rates need to be. As you know, the legislature the last 2 years froze rates for medical malpractice insurance, and but we are concerned about the underlying viability of the med mal insurance carriers. So there's a lot of work to be done. I agree with you, and look forward to working with the Medical Society to continue working on those issues.
Catherine Abate?
This doesn't necessarily address the issues of tort reform, and I know on the table isn't there a discussion about increasing reimbursement, not only under Medicaid and Medicare, but that doesn't solve all your problems. But one of the good things out of this bill is the creation, hopefully, of 15,000 more primary care providers in areas which are short of these kinds of providers. And this is through people coming out of medical school, out of residency, loan forgiveness programs, scholarships, incentives for doctors not just to go into specialty care, but actually go back into communities to provide primary care. And there's also going to be programs and money available to train more nurse practitioners and also deal with the shortage of nurses. Again, it doesn't address your issue, but it does help getting more doctors in the pipeline, at least in the short term, in terms of loan forgiveness, et cetera.
And one of the things we often say at the Cancer Society is just having an insurance card doesn't guarantee you access to the care you need. I wonder, Cindy Gillespie, you want to comment at all on the impact on primary care supply? We read a lot of stories in Massachusetts or out of Massachusetts about a crisis in the availability of primary care physicians.
Sure. Part of what happened in Massachusetts is when we moved to, with the individual mandate, when we moved towards full insurance, I think we're now at almost 98% of our population is insured, which is amazing as healthcare coverage. What happened at that point was when everyone had a card, they all wanted to see a physician, right? Everybody then now has a primary care doctor, but we didn't have an adequate supply. So what it did create is exactly what you began to see in the press, which is all of a sudden, with more of an insured population, less individuals using the emergency room, suddenly they did need more physicians, more nurse practitioners, just the entire supply chain really on the medical side turned out to be inadequate. So what has resulted from that has been a series of actions by our legislature, by our universities, really by the community there, which once there is a shortage, then all of a sudden you then begin to produce it, supply and demand begins to produce a need, and it begins to make the change. So part of what has happened over the years has been the recognition of, all right, now we have a fully insured population, we need more providers, we need more physicians, we need a larger medical community. The schools are beginning to produce it. The actions are beginning to have an effect. The supply is beginning to rise. It is not where it needs to be. And that's, I think, partly why you saw the Secretary talking about a side component in the bill is funding and programs to begin to encourage the development of the workforce all along the continuum. But it is an issue that does arise. Once you move to a fully insured population, you need a larger medical community to service it, or else you still fall back on everyone using the emergency room, and that does not create the cost controls you need.
Another question in the center back.
Yeah, a question for Ben. There's a limited amount of money for grants to small business to provide wellness and prevention programs. Can you comment on any details of that? How employers, small business can access those funds yet?
Actually, unfortunately, I can't. I don't really know much about that program. We've been focused on the tax pieces. Does anyone else know? I actually don't know anything about that program.
I know about the program. I don't know that I think it's like a lot of things in the bill, particularly around the grants, that there's going to be RFPs and other kinds of documents written that will basically flesh it out. So I don't think there's a lot of detail in the bill about that right now. I think it's to come.
I'll provide one comment, and that is that, one of the comments I made earlier was the biggest problem that small businesses face is managing this aspect of what they do. I mean, typically, when you look at a company that is, say, smaller than 25, it's the founder, president, CEO who is the HR rep, is the IT guy, does all of these pieces. And I think in that context, if you think about a company of that size trying to engage on wellness for their folks, it's hard for me to imagine how you make that work. I mean, simply put, it is enough to try to get small businesses to absorb the time that it takes to provide their folks health insurance and to build their company, to then layer in any additional work that isn't at the core of what their business does is a risky proposition. So without saying anything about the program itself, it's not the kind of thing I would expect small businesses to embrace simply because it takes them away from the work that they need to do to run their companies.